This session is really dedicated to childhood TB. So shall I give a bit of an overview this morning of burden of TB worldwide and restorations with consideration of restrictions implements. Here we have to speak about childhood TB. Okay, so it's about formation. Just a couple of So on this first slide is a bit of an overview of the burden of TB in childhood and the challenges related to diagnosing TB in children. So every year there's about there's about 10 million people that have TB, and among those are children. And among these kids with TB, more than 200,000 children die every year. Mostly because they have not been identified as having TB, so they were not able to receive any treatment for their disease. There's a major diagnosis gap in children. Why is diagnosis complicated? Well, TB is a very complex disease. Me and our clinician is taking forever to understand this disease. It's really complicated to identify. There are many symptoms that can be misinterpreted as something else, especially in children. And the tools that clinicians and health facilities have at hand to be able to diagnose TB are not always available at every level of healthcare and not always usable by every clinician. So, for example, one way to diagnose TB is to take a respiratory sample from a child and to test it with a specific test. And this is complicated because to get samples from children who are very young, it's difficult to expectorate when you're a child. So our clinicians really have difficulties getting samples from younger kids. You can also diagnose TB using chest radiography. So you take an image of the lungs. The thing is, sometimes the images, the machines that you have, just X-ray machines, are really low the quality, so it's difficult to get good images. And sometimes the capacity of the geographers to read the images is they don't have enough capacity. And as I was saying earlier, often the end result is that the capacity to diagnose TB in children is really concentrated in higher level facilities, tertiary level hospitals, and access to diagnosis lower level of care is limited. So that's the thing. One way to try and improve diagnosis, on which many researchers have been working on for several years, is to try and simplify the way a decision to say that a child has TB and to give the treatment to the child, to simplify that process. There are so many parameters that the clinician has to take into consideration that sometimes it can get complex when we're not skilled enough. So people have been trying to come with what is shown on this picture, which is an algorithm, which is actually a pathway to decision. So you go from one step to the other, and it tells you yes, no, go through one step to the next. And at the end, you can get a clearer picture of whether you can initiate the child for TB treatment or not. So basically, it combines a lot of different elements. It combines results from the tests I was talking about, results from chest X-ray, also the clinical assessment that the doctor is going to do by showing that the child has the different symptoms. So it puts all that together in an algorithm, and then the clinician's capacity to make his decision. So several people in the team involved in South Africa. Shisha as well works on these treatment decision algorithms for their TTAs. And the question that is at stake in the research that we're doing in the team at the moment is whether the use of these TTAs is going to help improve diagnosis, especially at low levels of care. And when I say, is it going to help improve diagnosis, this calls for so many underlying questions. And this is why in this project we're working on is really a multidisciplinary, interdisciplinary initiative. We're looking at so many different perspectives on TTAs. So one obvious is whether using these algorithms is effective. Does it increase the number of kids that are diagnosed with TD? Does it provide good quality diagnosis? Sometimes when you use an algorithm, maybe it's going to take you through a pathway, which is not really reality. Maybe what you see in the trial is a bit different. So is there a match between your clinical judgments and what the TDA is saying? Is using TDA something that clinicians like? Is it friendly for them? Is it challenging them in their capacity as a doctor? You have an algorithm that is telling you something, but you think you have your expertise and you're saying something else. So how does it work for health workers? Do they find it feasible to use an algorithm in their day-to-day activity? There's a lot going on in the facilities, in the primary care level, there's loads of kids or patients coming. Is using an algorithm in that context, is it feasible? Can it be integrated in a routine context, cities or district hospitals? The national TV programs in our context is the national TV programs who are implementing TAs. And the question is, how do they do it? How do they train healthcare workers? How do they support healthcare workers? What supervision do they provide? So it questions a lot integration of a new intervention in the health system and in the day-to-day routine of a national sector. How much will it cost? So obviously we deploy new interventions to train. You have to, we're in a specific situation, we're using digital tools also to support these TTAs. So that calculates. And is it cost effective compared to what we've done with the trade? Anyway, without. And finally, because it's what we are all aiming for in IPORA is to impact policy and improve public policy and improve practices. So the question that we're really interested in is how all this evidence is contributing to make the decision that TDAs can be included in a national strategy to be then deployed more broadly. So to address all these questions, where we come up with a really large scale and multi institution consortium that is called the SAEAP, and the SAEAP consortium has developed projects that basically has an implementation component. So the TDAs are implemented by the national programs, and then there's a whole research package that is coming to evaluate the implementation of TDAs. It's evaluated with this specific design, and I'm you know what it is. It's trial design, so it's experimental design with that TDAs, and it's done taking time into account. So basically, you have in each country, almost in Zambia, you have 4 health districts that are randomized, that randomly allocated in time to start the intervention. So the district 1, they're first by doing your intervention, standard diagnostic approaches, and then also later the district 1 is going to start delivering the intervention. And then to support later district 2 and then 3, later district 3. And at the end, everybody's going to be in a situation that they are delivering the intervention because we believe this intervention is actually beneficial and not have negative impact. It's a trial that was designed to be able to address both effectiveness and implementation questions. So it's really interdisciplinary by design. We want to know if it works, we want to know how it works and how to make it work. So that we will really reduce the time from evidence to implementation in real life, right? Yeah. This is what is implemented by the national TB programs. There are several TDAs that were developed over the years, several algorithms that were more or less fit depending on the profile of the children. We talk about kids with malnutrition, this one that really at risk of TB and at risk of being underdiagnosed with TB. So there's a specific algorithm for developed for him. There's one for those who live with HIV as well. So basically, there's a whole package of TDAs that are taught to healthcare workers. They can use these TDAs in a district hospital, primary healthcare level. They basically are doing that by compiling all the health data that they get from the GPs to enter it in the DHS2 system. We talked about it this morning. This is the district health information system that is in most countries now, that allows facility to have facility level and individual level health data. So the clinicians are able to enter the data in the system. So it's a digital tool. And then there's an automated system that calculates the TDA score for them. So as they consult with the child, they enter the data and then the score, and then they are told if they can initiate on treatment. There's also a specific component that Shisha has been working, spearheading a lot, which is the fact that if a child has non-severe TB, which is most children, they have a mild form of TB, they do not need to go for long TB treatment, as was the case for many years, with 6 months of treatment. Kids can actually only receive 4 months of treatment, which does not seem much, but it's quite a lot in the relevant child. 6 to 4 months of treatment. So all this intervention is deployed by the programs, by the national programs in local cases. And the program is using different strategies I was telling you about to deploy these interventions, training healthcare workers on the TDAs, deploying digital tools for the TDAs on the tablets when you enter the data, providing clinical mentoring for the healthcare workers, helping them navigate through this new intervention that they're using, and providing supervision. Programs that go every 3 months, every 6 months to facilities to support facility in doing what they're supposed to do in terms of health activity. So all of that in the package of what the programs doing is and us as researchers, we're a big team of researchers supporting the program to evaluate those findings, put into place a big multidisciplinary, interdisciplinary program. It's on this graph here, with social behavioral research, implementation research, health policy research, health economics research, and also epidemiological research on effectiveness outcomes. So we're looking at the TDAs from all these angles, and obviously there are cross-cutting questions in the different disciplinary perspectives, so that we get a full sense of how these TDAs are working one-on-one. We're using, we talked a lot about routine data this past few days. So using the routine health data from the facilities, both at the facility level, individual level. We're using the program data, so the supervision reports, the mentoring reports, all this is source data for our research. And then specific research data with questionnaires, with interviews from together perspectives from the beneficiaries, the end users, and the decision makers. So where are we now? This is my last slide. The trial is just ending now in both countries. We are analyzing the data as fast as we can because we are with an important deadline. For instance, people with TB is the World Conference on TB and Lung Health, which is held in November, and deadline is actually on the 10th and the 9th of April. So we're analyzing data as we are building the conference this week, so a bit intense. We're going to share findings on the effectiveness of the intervention of the TDAs, which brings together clinical research and epidemiological expertise. We are going to share findings on the acceptability and the feasibility of these TDAs. So we'll bring together our expertise in social behavioral science and implementation science, and sharing cost and effectiveness data. One challenge that we are trying to meet at the moment is to prepare for a multidisciplinary paper that we aim to submit to the INSETs later this year, a published journal, where we'll try and provide There's evaluation data from the multiple angles that I've just talked about, which is a big challenge, as you know, interdisciplinary behaviors. We're going to organize next year the international and country level dissemination symposium in Zambia, and we hope that some of you are here in the audience may be able to join. There are representatives of the Ministry of Health, programs, international stakeholders. The idea is to share the experience of how TDAs work and how we can make them work in real life, which is really interesting. And on Friday morning, we have a session on policy, translation research into policy, and we will share more insights on that, how we as researchers partnered with the national programs to speed up that process from research to policy, and specifically sharing the case of Zambia. I think that's it for this first presentation. And this is the consortium of African, European consortium. Thank you.
For that presentation, I think that the disciplinary approaches that is technically that we saw to philosophy. So I just want to like to invite some questions for Joanna from the members of the audience. Thanks so much. Thanks, very, very interesting. One question I have is, first of all, economics is just one piece is called analysis. Many of us have no idea. That's kind of a lot of things that is how do you go things that behavior is in your new environments, new etc. And so from this perspective, for this study, I was wondering whether it can be said
The translator. I think that's
So my point is, I was wondering whether but there are many studies that are in hospital, in other environments, for the new technology, new equipment. Also, well, I was curious to see how there are not three examples of new construction problem here, that still draws some of the second is in economics, we'll look at what we call distributional approaches. But it's the same number of people that get treated, it's not the same people.
Thanks, Sami. Maybe for the last question, I meant Clara or Olivier respond, on the profile of the kids who get treated actually. So is it the That's the second one. No, that's fine.
That's something. Where we use in clinical sciences and criminology is sensitivity and specificity. So what we have this Shishala, myself, other colleagues contributed to design those algorithms, which to re-explain briefly, kind of want to bring it to a scoring system based on things that a low-level or healthcare clinician is able to collect will kind of is helping them get the level of expertise that you can't get at the university hospital level. It's like bringing your best pediatrician in the country as a score to the primary healthcare. So what we use is sensitivity and specificity. We've designed those algorithms as recommended by the WHO, to be around 85% sensitivity. So it means that we think, and actually in practice, it usually increases a bit, that we would be able to diagnose adequately 90% of children with TB. It's quite sensitive. How we know, and it's another part of this discuss how is that they are not super specific. We are over-diagnosing TB. So in order to reduce the mortality due to TB, we will tend to treat more kids than CDC. So that's a bit the concept around those outcomes. It's accepted that to increase case detection, we reduce their specificity. And it's an area of work we still continue.
Yeah, and before was person was well to work with how many percentage being to the bottom.
Avevamo delle robe, però una delle
So maybe the first question really make you think of the vulnerability. It makes a lot of extra your health for issues reasonable. Yeah. The integrated management of childhood illnesses, which is another form of algorithm, is scored in the TB algorithm doesn't increase, but it gives you the same same spirit of the display, and you have a situation, and then it tells you yes to that, no, that proceed this way, proceed that way. And this type of algorithm is deployed at ground level in most countries of the world to support nurses and healthcare workers at low levels of care in making decisions and in managing kids in the best way possible with limited resources. So in our case, we try to learn a lot on that, knowing that healthcare workers appreciate an algorithmic approach and our actually mindset, the mindset is tailored to that. It fits with their clinical approach, to use an algorithmic approach. So it's based on this type of, experience with provider. And the change is probably going to be more using scores now on being able to move from a situation where you used to have to wait for a test result, and that test result to be able to treat the child. And now basically we know the algorithm is telling you maybe this kid is TB, so maybe the child will TB treatment even if you don't have. It's fine, more possibility, the kid is TB and it's probably going to do better for him. So in that way, this we don't have the answers for investigating in the treatment.
Maybe one question is you would have some over treatment cases where, right? So since the treatment is reduced from 6 to 4 months, it's still 4 months. So is there any side effect of treatment for treating your child would be have requirements? Starting being assessed, and then what can be done to increase specifically what's the trauma? Yeah, I think the algorithm it's developed based on world clinical study that take into account what clinicians in terms of what they also it happens. So even without having child with TB because of the risks and the mentioned in fact that some clinicians have stop some even this actually treatment or in some cases they to say treatment in itself is that's it. Really is to celebrations once you feel allows to so in terms of the side effects, I think any person who takes medication, and the side effects, and the side effects are due to non-trivial treatment. And therefore, when that she sees a job, second experience in side effects and profile. So it's evolving and more of the things that here, they are also it may just be that the software unnecessary thing is for the intervention and in this situation, that's a trade-off, and really to because we don't treat children that. So you want to use like you cast the lens, you catch a lot of it, like you catch some frogs, like but the whole world we want to catch those fish.
Yeah, thanks, Sean. It's global adverse events due to, adverse reactions to CT drugs actually. It's like, well, 8-9 drugs, things but
The next session, we're supposed to have a session on social determinants of TB by the share loss control, not level maintenance. And so we'll go ahead and proceed and listen to Mark then, who's going to talk to us about the knowledge TB proposal. Mark is presenting online.
Which one is the presentation?
The last one.
Bosch, last one. So,
Yes.
Please. Which one is Mac?
Hi.
Hi, can you hear me?
Yeah.
Yeah.
yes, we can.
Okay. Should I go ahead or?
Yes.
Yes, proceed.
Okay. Okay. So good morning, everyone. Sorry for not being here in person. My name is Marc Delbé. I'm a health economist and pharmacist working at the University of Bordeaux, the team, the GEEKS team. And so today I'll be presenting to you a pilot project we just submitted actually this month, on co-designing sustainable nutrition support intervention for tuberculosis-affected households in Zambia, with formative research aiming to inform a randomized controlled trial. And so this is a project we are developing with University of Zambia and Peter Ngoma. Just a bit of context on this. Sorry, still first slide, please. As you know, so this is an initiation grant to launch, to support researcher basically often in their early career stage to collaborate and test new IDP for scaling up interventions. So it works on a small budget, like 20,000 euros, with a study period of 1 year. And so here, the focus today is to present this formative research with a focus on the intervention design itself. Thanks. Next slide, please. So a bit of background on tuberculosis that Joanna just touched base on. Tuberculosis remains one of the leading infectious cause of death globally, with an estimated 11 million incident case in 2024. Undernutrition accounted for almost 9% of these cases, 1 million cases, highlighting the major role of social and economic determinants in driving the epidemics. And this is increasingly described, this relationship between malnutrition and tuberculosis disease, malnutrition leading to reduced immunity, increased vulnerability to bacterial infection, and the tuberculosis disease itself, leading to reduced appetites, reduced health, and reduced nutrition absorption, leading to malnutrition. In Zambia, there's a high child TB and malnutrition burden, with around 8% of children accounting for yearly TB cases, 32% of stunting among children under 5, and 1 in 5 children hospitalized that are malnourished and are at increased risk of tuberculosis infection. Next slide, please. Increasingly, what we observe is a global policy momentum linking tuberculosis and nutrition with, as many of you are aware, the United Nations Sustainable Development Goals on ending malnutrition by 2030, and more recently with WHO recommendations from last October, recommending nutritional assessment, counseling, and food assistance for people with tuberculosis and their household contacts. These recent guidelines also highlight some results from the RATIONS trial, linking nutritional intervention for TB prevention with the RATIONS trial in India, which showed a reduction of tuberculosis infection among household members receiving food rations, with high projected tuberculosis death averted and high cost effectiveness. What scientific evidence shows as well is that the effectiveness and sustainability of nutrition programs are also largely shaped by health system capacity, stakeholders' perception of these programs, locally relevant approaches, and competing policy priorities. So future research must prioritize locally co-design, context-sensitive and integrated nutrition support packages. And what the guidelines shows as well is that there's a lack currently on evidence on assessment and adaptation to local context for nutrition interventions, also adapted for this target group. So the general objective of this formative research is to inform the design of a randomized controlled trial, to implement and to evaluate locally adapted and sustainable nutritional support packages for households with children affected by tuberculosis and undernutrition in Zambia, with the implicit objective of enhancing integration within TB care and other existing nutrition programs. So specific objectives are related to mapping and assessing the evidence base of existing nutritional support programs in the health sector, their effectiveness, and importantly, their existing financing mechanisms in Zambia. Then to identify TB and nutrition-related outcomes for a randomized controlled trial that are most relevant to informing national and regional guidelines. This is also important because from initial discussions with WHO technical officers, designing a trial that is aiming to assess the effect of a social economic determinant on a health outcome will require careful RCT design in terms of effectiveness and characterizing this effectiveness, and ideally targeting outcomes related to mortality reduction. Third specific objectives is to co-design nutritional support programs with national stakeholders in Zambia in continuity with existing ones and lessons learned from previous assessments, such as some presented by Professor Peter Angoma. And finally, to inform the design and grant application of an interdisciplinary RCT to assess adapted, effective, acceptable, equitable, cost-effective, and sustainable packages of nutritional support. Next slide, please. Just a brief word on the methodology. So the mapping of existing intervention support programs in Zambia currently is focused only on Zambia, but depending on how the design may evolve, we might also expand to other neighboring countries. So desk reviews of national policies, program documents, donor reports and guidelines, as well as key informant interviews with national stakeholders, UN agencies such as UNICEF, Global Funds, and other implementing partners in Zambia. For specific objective 2, on identifying outcomes for the RCT. So this will also be based on scientific literature review and key informant interviews with Zambian stakeholders, with researchers, including researchers at IPORA, and the WHO technical staff with responsibility to developing guidelines. Next slide, please. In terms of specific objective 3, when co-designing candidates nutritional support packages. So we have a participatory co-design workshop with participants listed in the previous slides to agree on 1 to 3 candidate intervention packages to include it in the trial. Here, the point as well is to make sure that we also adopt an intersectorial approach from the start of the research, because here our focus, or at least our rationale and hypothesis, is on TB care and TB related outcome. But obviously we know that there are many other interests and many outcomes of interest with nutrition interventions. Define, so an outcome of specific objective 3 will be this define and stakeholder intervention packages with clarification on eligibility criteria, delivery mechanisms, frequency, duration, supply and production considerations, such as locally produced nutritional supports, nutritional packages, nutritional food, and but also included in these intervention packages, which is not listed on the slide, are scenarios of funding mechanisms, potentially also influencing package design. And lastly, in the identification of priority areas with national stakeholders. So this will be based on national program priorities, but can also be potentially informed by research. And for example, I don't know to which extent some of the work with Dr. Fuemba on spatial modeling is being discussed with national programs in terms of identifying priority areas, but potentially that's something we'll be interested also to collaborate on. And last specific objective, to inform the RCT design, develop the grant application, so that is at the end of the year of this pilot project, draft a trial protocol outlining study sites, priority areas, eligibility criteria, sampling randomization approach, intervention outcomes, sample size, costing framework and implementation evaluation components, a full grant proposal with a targeted funder for this, a scientific committee also involved at this stage, including stakeholders led of support and implementation plan aligned with national and international TB and nutrition priorities. At this stage, we have also initial discussion about expanding, the RCT to other potential candidate countries with whom we have experience working on tuberculosis research, such as in Mozambique and Zimbabwe, but potentially also other IPORA countries. And the application will be written during a GRI grant writing workshop, also inviting core investigators from UNZA. And potentially, we also welcome other collaborators from IPORA. In terms of expected impact, several levels. So short-term impact will be to strengthen national coordination of TB nutrition and social protection stakeholders. Produce clearly defined candidate intervention packages, and enhance national readiness to mobilize external funding and potentially leveraging domestic funding sources, but also at the stage of the design. Medium term will be probably the result of the RCT, informing which strategy to adopt and how to integrate into existing ones. And longer term will be to inform national policy and international WHO guidelines, and improving nutritional and socioeconomic outcomes for vulnerable households affected by TB in Zambia and globally. So thanks for your attention, and we welcome any question.
Those that we have global candidate. So on behalf of my co-chair this morning, we are hoping to use sessions on the access of faith and authorities of giving us a flavor of what we can do in terms of disciplinary work. And the opportunities that IPORA uses to collaborate further. And just on behalf of this, so as people can come on board and on this health focused access, so that we can the long more to the scheme work related to this. And so
Yeah, and I was thinking again about Tom's question about the intervention that in economics you are looking at the drivers of one person, healthcare workers, taking up a new intervention. And I said, oh, we look at the things from another angle as behavioralists are. Yes, we do. We look at the incremental cost-effectiveness ratio, which is not something that the other economists look at. And it reminded me of yesterday, I was reacting to a presentation by Julien and Yusra. I said, oh, in my field of work, I would do things that, and I think it's a good, lesson learned from discussing the people from different disciplines. Here, as you understood, Mark is proposing to move to a more economic RCT, but I'm sure we will be facing, once we have done our Decide TB study about treatment decision analysis, we will be facing one thing is that probably the WHO will have enough evidence to integrate this in their guidelines, but then it will go down back again to the health facilities and to whether people will adopt it. So Joanna mentioned IMCI. I don't know if it's all or integrated management of illness. It's like simplified algorithmic approaches to management of childhood illnesses. And it's very simple, but in fact, in reality, there's like this, a lot of healthcare workers do not use. They use different approaches. They are trained, taught, supported to do it, but they don't use it. So I think maybe IPORA, we can discuss more with some of these who are like doing microeconomy, mistaken, that's what you guys look at. What are the drivers of choose or the community health workers or to adopt this intervention or not, because they can actually not really need to get drugs, they can just give antibiotics as they feel rather like it. So I think it will be interesting within our core discussions to see how we can have the economists, like the core economists we do. And also as a calculate from Canada, I think we have to use the way that this goes from all that service, so we can discuss it with colleagues here in our parties, because maybe there's interest in the TV program here that is implement this, and it will be a nice, cross-fertilizing initiative to have you guys in such extent. That is the thing bring together. I think it's very much. Smart regulars situations. So one of the things here in Johannesburg, we are doing one is called the problem of wash after wash. So we are doing something. We are trying to use behavioral interventions. How can households in Canada in different places of Ethiopia adopt those interventions and behavioral bias. So it's a approach that's delivered in behavioral economics and some advances in behavioral science. So the idea is, and that's what I think he mentioned. When we say health economics, we should not just think effectiveness. We should also think the main issue in health economics is that there are so many beneficial interventions that adoption is not. How can you use ranking and different tools if you are doing it in Ethiopia for the past 2 years at least? So I'm really calling upon colleagues here in Ethiopia to see how we can also collaborate in this knowledge TV and push it further to adopt certain things that are addressed. Thank you.
Thanks, Peter, for that addition. We still have another 5 minutes. I will comment, please. So I'm not new in this area, so I just wanted to know if you get to see the same kids being maltreated coming back again with TB, and when I get back kids, the nutrition support at home may play a role. So I just wanted to know if there's been kinds of repeated TB, from human child, and then does it help to work on the background? Interesting question. So in general, it's permissible to be in children not very good compared to adults. Nutrition is very important in the concept. So not only improving nutrition, that's not protecting it. It's treated as a power is in this country. So that's really very important a consideration. I think that decision back for our TV and things wow. And here is the center. It's really carefully the score of things that we can have can benefit.
They just say that the ration study that Mark alluded to in India, you know that at the time in India, in adults, preventive TB treatment was not given for contacts. So I had TB, my brother could not get the preventive treatment. But now it's recommended by WHO. So what they did at the time is that they randomized people to do things as usual or receive nutritional support. And nutritional support decreased incidence of TB in the household. So I have TB, and in fact, my kids, people around you will get it less as they get more food. We knew from decades ago that TB is a disease of morbidity. TB touches people with better nutrition. We know it's a risk factor. It has said we need to move forward. We need to provide food, but we don't know how to provide it in a cost-effective or in a behavioral change acceptable way. So this is why we are starting this work, because we know from our field that sometimes something is recommended at the regulatory level and it's not adopted at county level or not by healthcare. There's a whole chain of things to look at together. If I didn't place your point, most of the diagnostic and also it has to do with the reason is about as I see it with experts. But common beliefs now is that there is a problem with the research from cheap, the child and even the one of makeup. Exactly that one on PTV.
Yes, thanks for that question. Yes, how this color TB is common in children compared to adults. But even in children, how TB is still makes the largest child TB. So the TDS help provide data for common activity and lymph node diseases. And we know that lymph disease contributes quite significant jump next to TB. So there's still powerful TB post disease that the TB doesn't address the only not the one there's no significant power. So in that situation then healthcare provider needs to have the child needs to be identified as a patient who is wrong as diagnosed in those forms.
Merci. Chapitre. Alors, concernant la tuberculose au niveau des enfants, je suis toujours posé la question des facteurs, ou je ne sais pas comment vous appelez, entre la nutrition et le VIH. Quelle est l'option qui impacte le plus l'enfant au niveau de la tuberculose ou les gluts? Qu'est-ce que ça va? Bon, c'est une question, j'aurais pensé à l'avoir
One balance in a environment with family and primary surgery of bakers about for meals and their ability to find the children, and therefore that makes the child susceptible to infections and problems. In a similar manner, HIV does and face the child's immune system from their ability to fight infections and therefore susceptible to it. So in a way, they both act in a similar manner, and when you have the two of them together, then that's even worse. But in terms of which one is bigger, if you just refer to the road reports that are getting to the system, they quantify which factors contribute to cause to start the development TB. And that biggest contributor globally, adults, the biggest contributor to somebody developing TB is undernutrition. And there is still more This is because the documented people are getting recognized, the service, there's a lot of contribution that this came from which I see this. What you can see. I think. On points and a number of issues related to this access and global health and inequalities, as well as the risk of poverty. I'm still open to lots of collaboration on that time. For how we going to join the groups and hope that spreads the message, the event programs in this session to contribute to organizing that and the success. I want to thank my co-chair, John, and all the presenters from this morning. Thank you very much.